John, you want to share your screen?
Yep.
Perfect. All right, everybody. So welcome to the next session of Virtual Global Spine Conference hosted by Dr. John Caridi of UT Health Neurosciences in Houston, Texas. He is he's an associate professor in the Department of Neurosurgery at the McGovern Medical School of UT Health. John is one of my foremost mentors and one of my best friends. I've known him ever since I started residency, and he was very instrumental and crucial in my decision to go into spine surgery. So this is, in my opinion, the man, the myth, the legend, Dr. John Caridi. I'll let him take it from here.
Thank you, John, for your nice introduction. Obviously, I've known John ever since he was a resident, and I appreciate you inviting me to give a talk about something that I like to take care of. Believe it or not, I actually do like to take care of this because I feel like these are some of the most grateful patients after you're all said and done with them. So I'm going to talk about revision surgery for iatrogenic flat back. So I'm not sure who's originally said this. There's a lot of different people who are credited with it, but all spine surgeons are deformity surgeons. Either you're correcting the deformity or you're creating the deformity. And the goal is to not be the guy who is creating the deformity and to try and maintain a normal alignment when you're putting in your instrumentation and fusing these patients.
John, I'm sorry to interrupt you. I think you may be in speaker mode. I see you at your slides as speaker mode. Do you guys see that as well, or is it just me? Not Ali, do you see that as well? Yeah, okay. You may have to cancel it out and hit view slideshow.
All right, hold on one second.
Oh, right there, John, right at the display settings. You can also change that if you like.
Sorry about that.
No, that's okay. I gotta try and. All right, are you still seeing speaker mode?
Yeah, we can see your screen now. Just hit the view slideshow button on the bottom right there. Should be good. Maybe just go to, there you go, yeah. You want to hit slideshow on the top there, maybe? And then, yeah. Yeah, maybe it's one of those. Okay. Worst case scenario, just keep going, I guess, man. It's fine. Yeah.
All right.
Yeah, this is fine. We can see these slides.
You guys can see everything okay?
Yeah.
All right.
Yeah, looks good.
All right. So I lost my role. So this is a paper that everyone in spine surgery needs to be familiar with.
Sorry, now we don't see that. We don't see your slideshow again. You have to cancel out, and what we see is that little button, slideshow, resume slideshow.
Are you serious?
Yeah, you're gonna have to cancel out. There you go. Try sharing your screen again. Just make sure that the one you select is the one showing either your computer screen or your PowerPoint slide. There you go. I think this looks, yeah, there you go. Perfect. You're perfect.
Okay. All right. I'm gonna try one more time. All right. So this is a paper that everyone should be familiar with. It's one of the classic papers in spine surgery. This is Steve Glassman's paper from 2005, showing that sagittal balance is the most reliable radiographic predictor of clinical health status in adults with spinal deformity, and that increasing SVA correlates with worsening pain and disability. So part of this concept is to understand that there are compensations and reciprocal changes whenever the spine has a force acted upon it. So a compensation is a change in a given direction that is counteracted by a conscious or an unconscious change. So we classically think of bending your knees, or a patient bending their knees when they have a spondylolisthesis, and that's because their spine is actually in kyphosis at the lumbar sacral junction. And as a response to positive sagittal malalignment, the body progressively recruits its compensatory mechanisms. And that's of the spinal elements and the non-spinal elements. So you typically see things like hyperextension and retrolisthesis, and your goal is to maintain that gravity line. So you can end up with hyperlordosis of the cervical spine because we want to keep looking forward. And all of these reciprocal changes will actually cause worsening forces on the spine that can create pain and disability for our patients. And a classic example of that is seen in our adolescent population. So this is a young girl. We're obviously drawn to the coronal curve, but the thing that's most important in her is her lack of a thoracic kyphosis, and also her cervical lordosis is reversed and she is actually kyphotic. And so we actually need to consciously correct her thoracic kyphosis. And so when we correct her scoliosis, we build that kyphosis into her thoracic spine, and then you can see how her cervical spine reacts to that and maintains her gravity line. And Roussely has done a lot of work regarding the types of the pelvis and how the pelvis itself is what dictates the shape of the spine. And I don't want to go into all the different types of Roussely pelvises, but just to know that the arc of the pelvis, the pelvic shape and the arc of the lordosis is what gives the spine its shape, and what we need to be conscious of when we're doing spine surgery. And so this led the European Spine Study Group to propose this global alignment and proportion score, or the gap analysis. And this was published in JBJS, I think in 2017. And this is something that I use pretty routinely now. And the idea is it offers a personalized sagittal plane analysis instead of relying mostly on the published norms of the ISSG classification. And it basically uses the pelvic incidence, and instead of using absolute numeric values, creates an ideal pelvic tilt, lumbar lordosis, and global tilt based on the pelvic measurements. And so it gives a relative measurement, and all of those relatives should be 0. So it gives a relative pelvic version, relative lumbar lordosis distribution index, and then a relative spinal pelvic alignment, and then it adds in an age factor. So this is basically what they're talking about. And so it looks at the relative pelvic version using the sacral slope and the pelvic incidence, a relative lumbar lordosis. It takes into account the distribution of the lumbar lordosis, knowing that from L4 to S1 should be 2/3 of your lumbar lordosis. So it actually builds in that equation for the distribution. And then it uses the global tilt for the relative spinal pelvic alignment, and then adds in an age factor. And all of these together creates a range from 0 to 13 points. And then So with 0 to 2 being well aligned and proportionate, 3 to 6 being moderately disproportionate, and then greater than 7 being severely disproportionate. And the key thing to understand is that this is not a scale that's looking at patients who have a native spine. It's looking at how patients should be fused. So if preoperatively you're looking at somebody's gap score, it's not necessarily relevant to them because their spine is still not fused. It's relative to the patients who you are fusing, and you need to put them in that proper alignment. So it's very important to understand that the fused spine has completely different mechanics than an unfused spine. So I think it was Dubusse who said that life is a kyphosing process, and spine surgery is a flat backing process. So the important things to understand are to keep that patient well proportioned. So this is an example of a patient who showed up in my office a few years ago. He's a 48-year-old with severe back and leg pain. He'd been through the typical non-operative therapies. And you can see this is his analysis, and his gap score is 11. He's got a severe flat back. He's got very pronounced sagittal malalignment. His SVA is very positive. You look at his pelvis, his sacrum is parallel to the floor. His acetabulum is way out in front of his sacrum. So he is very much retroverting his pelvis. So, but the key with this guy is this is not a fused spine. So this guy is doing this essentially to himself because he's only 48 years old. So when we looked at his MRI, he has this very small disc herniation, but we thought that might be enough that it's causing him to compensate this much, causing severe back spasms. And if you look at his supine MRI, he has significantly better lordosis than he did on his standing x-rays. So he was originally recommended for a T10 to pelvis with anterior with the hyperlordotic A-lifts, but we ultimately just did a microdiscectomy on him, and he improved significantly. This is his X-ray at 6 weeks. You see his SVA has corrected almost completely. His pelvic version is much better. You see his sacrum and acetabulum. You can see how much he's now not retroverting his pelvis. His relative lumbar lordosis is much improved. Still has a little hyperlordotic maldistribution and a mild positive malalignment, but his gap score went from 11 to 4 with just a microdiscectomy. So this is an example of somebody with an unfused spine that we need to be careful that we're not going to potentially do something much larger than we really need to. So let's talk just for a moment about iatrogenic spinal deformity.
Hi, John. Hi, this is Ali. I'm sorry to interrupt. Can you hear me okay?
Yeah, I can hear you.
Great. So can you go back to that case? Thanks for presenting today, and what a terrific, really phenomenal case to start with. But I think it is so important that if we can just spend a minute or what do you look for what parameters do you look for? How do you assess something like this so you're not doing the wrong operation or the unnecessary operation? So we see this a lot, right? Patients come in with severe lumbar stenosis, a large herniated disc, their posture is off, their scolioforms look terrible, but their lumbar stenosis. What do you use in your practice, like the 3 or 4 or 5 things that you look at to say, well, hold on a second, that's not a structural deformity, that's a reactive deformity. Can you share with us what you look at specifically?
So I think one of the first things I look at is basically how the patient is carrying themselves. And full disclosure, I had disc herniation myself. So, and I know how bad it hurts. And I know that my back muscles went into really severe spasm and pushed me really far forward. And so I look at how they're walking. That's basically the first thing I look at. And if they're walking with that kind of duck walk in a way, where you can tell they're just bracing themselves, that's one of the first things I look at. Then just feeling their musculature in the lumbar region and how tight it is. And so you can tell that their back is really in spasm. So something like that, that puts in my mind that it's not something that is necessarily a structural problem, but maybe more of a nerve and muscle spasm issue. And then, for example, like what you talk about with the patients with really severe central canal stenosis and claudication, typically when they stand up and they start walking, they start out and they're fairly erect. And then as they walk, they start to pitch more and more forward. So that's another thing that I look at. And then basically what their complaints are. Is it mostly leg pain? Is it mostly back pain? Do they have that classic flat back complaint of I'm okay in the morning, and then the more I do during the day, I just get gradually worse and worse and worse? And is their leg pain more from fatigue of the leg muscles than it is from radicular symptoms? Those are all things I look at when I'm trying to assess, is this a structural flat back issue, or is it a more of a muscular and neurologic flat back where they're actually just basically trying to push themselves away from their pain? So those are the things I kind of look at.
Thank you for that.
Okay. Does that make sense? All right.
Yeah, no, absolutely. Thank you.
So there is not a lot in the literature when you talk about iatrogenic spinal deformity, either because we don't really want to talk about it or because it's not necessarily studied. The rates vary from, depending on who you read, between 15 to 75% based on different ages, pathologies, levels treated. This classification is not something that's typically used. I found this in a neurology textbook from 1992 or something like that. It was, so, but as you can see, it actually does talk more about what are the causes of iatrogenic deformity. And what you notice is none of them are necessarily flat backs. They talk about more pseudoarthrosis and then adjacent segment disease. So we don't really know what the rate of failure is of our fusions because we are putting patients in compromised positions. So I did just want to touch on this, and this is what exactly are we going to do when we talk about correcting these deformities? And typically, you're going to end up doing some manner of osteotomy. And this is the classification that Schwab published, I think in 2015, basically just describing each type of osteotomy. So where type 1 is an inferior facetectomy, type 2 is a Ponte or a Smith-Pete, type 3 is a PSO, type 4 is an extended PSO through the disc above, type 5 is a VCR, type 6 is a multi-level VCR. Each one giving you increasing amounts of potential correction. So this is a 48-year-old who showed up in my office having had multiple surgeries in the past. She's, despite this being in New York at the time, she's Texas-sized. She came in with severe low back and leg pain. This is one where I definitely did not need to see her walk to know what her problem was going to be. John, tell everybody what this is.
It's a lumbar arthroplasty.
Yeah, that's the old pro disc.
Yeah.
So
you know, it's funny. Well, I don't want to spoil it. I remember this scan. I think you and I operate on this patient.
Oh, okay. All right.
I'll just remain silent.
Okay. So she had, what you can't see because of the obscure, is that she had an ALIF. She had this arthroplasty done. She then had a posterior fusion with screws spanning from 4 to S1. Then had a standalone XLIF on her CT scan. This is a pseudo here. This is a pseudo at 4.5 because that was never going to fuse. How do you typically pimp the audience?
We can just ask them, give us some options, or we can just maybe open it up to the audience what they would do. You can type it in the chat box, and I'll read it out to you, John.
All right. So, so somebody in the audience, tell me what considerations they might have for this patient regarding their. First of all, do they think this is just a pseudo problem, or do they think this patient, obviously since we're talking about flat backs, that this patient needs some kind of osteotomy? And how extensive do you think it needs to be?
Some people are asking if you had any more advanced imaging, so there's CAT scan or MRI.
So MRI just looks like a black ball of nothingness because of this arthroplasty. The CAT scan shows a pseudo here and a pseudo at 4.5, and then 5.1 is solid diffuse.
Did you get a myelogram for this patient?
She did have a myelogram. She doesn't have any significant stenosis.
Okay. Those are some of the things people ask. They would want advanced, more imaging, meaning CAT scan, myelogram, MRI.
Okay. So,
what about choice of approach? Back, front only, back only. What would people do here?
is this a good candidate for, say, an anterior column release and a percutaneous, say, fixation from L2 to S1?
John, I'm sorry, I'm having a hard time seeing the scan. What the instrumented levels are? What, L4 to S1 or L4 to L5?
L4 to S1. There are screws here.
L4 to S1, and is she fused in the back?
She's fused in the back from at 5-1, but not at 4-5.
Okay, got it. Yeah, for me, I would try to do as much work, honestly, anteriorly as possible. I would take out the rods, do as much work anteriorly if I can, give her that, try to take out that artificial disc, try to get some realignment there, and then the rest from the back. I personally would try to get some work done from the front first.
Okay. Do you have much experience taking out arthroplasties from the ALIF or lumbar arthroplasties?
So
I've never done it.
Obviously, yeah, a little bit more experience with the cervical. The lumbars are harder, but probably took out one from the side from an XLIF approach.
Yeah.
But if not, I would still try to do some work from the front.
Yeah, because with the Pro Disc, they cut those keels
They do
into the vertebral bodies. So if a third of the vertebral, you got to get rid of, if you're going to come from the side, you have to get rid of a third of the vertebral body of 4 and 5, and then in order to pull that thing out. Or you're going straight from the front with the veins scarred down over it.
Yeah,
so
that's a talk with a vascular access surgeon, and I would try that if we don't think radiographically it makes sense, then you obviously can't do it if you don't feel like it's safe in your hands.
Yeah. So, that's what I was considering with lumbar or with anterior. And then as far as doing an ACR, I don't think this is a good ACR case because she's extremely flat from 4 to S1. It's hard to see the S1 end plate, but it's here. But she's extremely flat from 4 to S1. So she's maldistributed. The majority of her lordosis is actually at this disc, which is 2-3. So I didn't think giving her more lordosis at 2-3 is really going to help her. Nor do I think taking out the 4-5 XLIF and trying to do an ACR at 3-4 would help her either. So ultimately, the person who put in this arthroplasty did us a favor and didn't without doing her a favor, because what we could do is we just did a posterior column osteotomy through that segment, and we're able to fish mount this 4-5 arthroplasty to restore her 4 to S1 lordosis. We did more posterior column osteotomies through L3-4 because this was a pseudo. We basically were able to use that XLIF cage as a lever and bring her back. And she ultimately did very well. Gap score is not totally perfect, but much better than it was before. And we actually got away without doing a major 3-column osteotomy. Questions about a case like that? Nader, would you have done anything differently?
No, I agree. I mean, I'm always reluctant of doing any revision anteriorly because of the issue with the vessels and, scarring and the unknowns. And it looks great, taking advantage of the flexibility of the arthroplasty device and releasing the posterior column. And that's all you needed to do. Now, in terms of where you can stop, you stopped here at what level?
T10, yeah.
T10, yeah. I mean, it looks great. stopping shorter maybe would have been sufficient, maybe, but like, yeah, the options were to stop cranially are not too many. It's T10, T11, then your next stop is T4, and then, so it looks beautiful. But I agree, it's everything is a risk benefit. I'm always reluctant of going and doing a revision from the front because of all these unknowns. And even if you can look at it on the preoperative imaging, you can't predict how flexible or how scarred down these vessels are on mobilizing them, and what have you. Yep.
Yeah.
Let's,
and for the younger people out there, when the Charité first came out, which was the original artificial disc, there were a string of infections and quite a few deaths when they went to come and take those things out from anteriorly, because the vascular access people couldn't even tell where the vessels were. So you ended up having to do bilateral iliac vein stents and bilateral iliac artery stents in order to protect the vessels before you went in to try and take these devices out. So it's not a small thing to go and do a revision anterior surgery. All right, so another fun case. This is a 63-year-old lady who's had multiple surgeries. She's fused L3 to the pelvis. They ended up skipping her S1 screw, and these are actually 4 iliac bolts. And then this is 3, 4, and 5. Here, her this is her sacral end plate here. So you can see she doesn't have much of lordosis. She came in with the classic complaints of severe low back pain worsening throughout the day, can't stand up straight. And then, by the way, I have no advanced imaging on any of these people. I just am showing you their x-rays. She is not stenotic anywhere, and she is solidly fused at these segments below. What are some of the considerations for this one from the audience? Or questions?
John, some of the questions people are asking are maybe related, more for the last case, but also related to this case. Are you quad rodding at L5-S1 routinely?
So if I'm not doing an osteotomy, I generally don't quad rod at L5-S1. Basically I'm always putting in iliac bolts, and I'm typically not putting in 4. I'm just doing 2 S2AIs and then S1 screws. So I'm not typically doing 4 rods at L5-S1.
And could you comment in relation to coronal alignment, which indices you use in your practice, Bergeon classification, et cetera?
With regards to the coronal alignment, basically I'm still using the SRS Schwab classification as far as the coronal alignment goes, and how far off of the center sacral vertical line the patients are, and what type of trunk shift they have. So still maintaining that part as far as the coronal alignment goes. But coronal alignment, unless you have a really marked trunk shift or shoulder imbalance, has been really shown to not be as important as sagittal alignment. So In just looking at this lady's sagittal view, though, you can see that she has a pretty marked coronal deformity. I don't have her AP to put up here, but so she actually has a pretty marked coronal malalignment. So she required a little bit bigger surgery. Essentially, we wanted to get as much lordosis as possible. So we ended up doing an extended PSO with her at L3. And because of the coronal alignment issue, we ended up going up to T4. And she ultimately did well. So the main reason to go to T4 in her was not because of sagittal problems, but mainly because at T10, 11, where we normally would be stopping, is where she had the apex of a coronal curve. So we ended up having to carry her much higher up.
John, do you stage these procedures, or what's the surgical plan and that you follow in these big operations? I mean, the patient already has hardware, and you want to extend her up, and then you need to do a PSO or an extended PSO. What's how do you go about that?
So I tend, for a case like this, to not want to stage it. I'll show you the next case is one that I did stage. So I feel like this I can get done all in one day, and I feel it's better for the patients to have surgery basically all in one day, even if it is something this sizable. I feel like if the longer they're in the hospital, the more likely they are to have a problem. So as long as I feel like the patient's healthy enough, if anesthesia is on board, then I'll try and get this all done in one day. We use a lot of tranexamic acid. We started using topical tranexamic acid as well, both in our irrigation and on our sponges, to try and prevent as much blood loss as possible. And basically, in a case like this, we'll be able to get it done fairly expeditiously. So,
John, can you comment on the SVA? Do you think it's negative in this case?
So let's see. Here's the back of her sacrum. Here's C7. So I think it's very close. Her global alignment ended up being okay. For some reason, this X-ray cut her off her head, but it ended up being okay. All right.
The other comment for the audience is the goal of the iliac screws always is to offload the sacral screws. So it's not to replace them. So you're in order to achieve a fusion at L5S1. So a lot of people like, we got to emphasize that L5S1 fusion is critical to take place. And the goal in long constructs to have that take place is to offload the sacral screws by placing iliac screws. But the iliac screws are not there to replace sacral screw placements.
Exactly. Yeah, then it's 5-1 is, other than the site of the osteotomy, is going to be the most likely place for a pseudoarthrosis. And so you definitely want to have screws at both 5 and 1 if possible. And yeah, for sure, the iliac bolts are not meant to replace sacral screws. And what Nader means by offloading is, the sacral pedicle is generally very large. So if you're putting a screw into it, you're not catching all of the cortical surfaces. You're basically putting it into cancellous bone. And, even if you punch through the front of the sacrum to catch it bicortical, it's still not as good a fixation as generally the other pedicle screws. And if it's the last screw in your construct, it can basically tear a hole through the sacrum as it's trying to support the weight of the spine. So that's what we mean when we say offload the sacral screw.
John, a question from the audience. How often are you placing L4 to S1 cages in long constructs such as this to prevent lumbosacral rod fractures or osteoarthrosis?
Almost 100% of the time. She was already fused 4 to S1, so I didn't have to do it in her, but I almost always want anterior column support, usually via a T-lift, but occasionally we'll do a 2-level hyperlordotic A-lift to try and correct somebody who's may have really severely degenerative disease at the bottom of a long construct. So I always want anterior column support. Does anybody do anything differently?
I totally agree. That's exactly what I do.
All right. So this is a lady who came to me. She's 43 years old. She had scoliosis surgery as a teenager. She told me that 2 weeks after her initial surgery, her rod had come out basically through her skin. And the surgeon in the office cut off the tip of the rod and sewed the skin over the broken shard. So on examining her, there's basically about 4 or 5 epithelial cells overlying this rod right here. And it had been that way for a couple of years. So she obviously now has severe low back pain. She was not fused at 4.5 or 5.1. And you can see this is all wired in here. And you can see that she is kyphotic through her thoracolumbar spine. So this is kind of a nasty case. So I can tell you that this was I did this pretty early on in my career, and this was my virgin experience taking out wires from somebody who'd been fused 10 years before, or actually, no, I'm sorry, 20 years before. And that is really unpleasant. It's a very bloody, not fun experience. So, and it does not take zero amount of time either. So this was one that I was very glad that I staged. And what we did was the initial surgery, we removed this construct, and then with navigation, this is also one of the few times I use navigation because this is essentially a solid piece of bone and with no landmarks whatsoever. So with navigation, put in our pedicle screws and then closed, waited for about 10 days, and then took her back to do an osteotomy for her. So what extent of osteotomy does the audience think that we need for her? I didn't give you the measurements, but if you look, she's maximally compensated because her sacrum is completely flat. Here are her hips, kyphotic through the lumbar spine. So you know that you need more than 30 degrees of correction just by looking at her. So this was one where we actually ended up doing a lumbar VCR to basically get her as much correction as possible. And this is also one where you can't see it well on the lateral, but we actually had 4 rods across her lumbosacral junction and across the osteotomy site as well. So this was an unfun case, but very much worth it. She did very well ultimately, and you can see she's still a little positive. So I didn't correct her 100%. So one of my colleagues in New York probably one day will be fixing this again.
That looks great, John. That looks fantastic. For these, I was thinking for this case, I was thinking of, it's hard to see how if she was fused from L4 to S1 or just below that previous construct. But would you consider doing ALIF on her to just get some more lordosis over there?
I would, and I think that actually would have been very good for her. And I think that if we had done hyperlordotic ALIFs at 4.5 and 5.1, that would have actually made our lives somewhat easier. So, yeah, thanks. Cleaning crew comes at 6. Sorry. So yeah, hyperlordotic ALIFs would have been a great option for her. So,
actually, great question, John. What is your PJK prevention strategies in a case such as this? Do you use tethers? Do you use cement? Transverse process hooks? You try to go for soft landing?
So I have found that I've done almost all of those things in the past, and none of it really works because I don't think that extra support in the posterior column helps that much. So the transverse process hooks and the Merceline tape and even the flexible rods at the top don't make a huge difference because the problem is anterior column fracture. And even with cement, you still see those fractures anyway. So my main way to prevent PJK is to make sure that their alignment is totally correct, or as correct as I can get it in the lower lumbar spine. And then I keep them in a orthosis for basically 3 months after surgery. I don't know if it really helps, but one thing that I feel is an issue is that patients' brain is telling them that they need to be pitched forward because they've been pitched forward for so long. So that may have something to do with it. And if you remind them to not pitch forward, then maybe they don't. I don't want to say my PJK rate is 0 because it's not, but I feel like it does help somewhat. It at least helps me. What do you guys typically do? Nader, what do you typically do?
To prevent PJK?
Yeah.
So yeah, I use I mean, I don't want to mention companies, but let's throw it out there. The Nuvasive Versatile,
Yeah.
And that's like, let's say if I end at T10. Also, I consider it like a smoother transition, hooks at the top, and also the Versatile. So a couple of these, and they make a difference, especially with the what do we call spinous process augmentation techniques. They help decrease substantially the rate of PJKs. We've seen that. My colleague, Dr. Koski, who does many more deformities than I do, has also noticed that substantially, like over the past 3 years, rarely we see PJKs compared to the case like 4 or 5 years ago.
Wendy, do you do anything different?
For this case?
No, Wendy.
Wendy, okay, sorry.
She's not listening. That's okay.
John, what we typically do, we're big fans of cement and transverse process hooks. If we're nabbing the case, we'll do perk, 1 or 2 levels above that, and just connect it with the construct.
Okay. All right. Lots of ways to skin a cat.
Yep. Are any of them better than each other? I don't think so. You still see PJK even with the best of efforts.
Mm-hmm. For sure. All right. So this is my last case. This is a 32-year-old woman who showed up at the office with with obviously severe back pain and frequent vomiting. Basically, you know, when you looked at her xiphoid was essentially pinching into her stomach. So, you know, she's from Tibet originally and had a history of an infection as a child. So this is a post-tuberculous kyphosis. So we recommended what you typically would do in a case like this, which is a 2-level VCR and correction. She went elsewhere and came back to us a couple of years later with this in place. So and obviously no resolution of her symptoms. So basically what the other surgeon had done was a 2-level VCR, but he didn't do any correction, basically just put a cage, which is sitting on basically the anterior lip of this, which is T10. And she still is just as kyphotic as she was before. So this had all been done posteriorly. He had done a costotransversectomy and taken the body out basically on one side. She still had bone on the other side, and put this cage in and tried to basically lengthen her spine. So for the younger members of the audience, you can never lengthen somebody's spine. It does not work. So you can shorten the spine in order to correct it, but you cannot lengthen somebody's spine. So what do some people in the audience think of this? Anterior, posterior, lateral? What would you do, John?
I'd buy this patient a plane ticket to Houston, and I'd send him. No, I'm just kidding.
No, I don't doubt that.
Yeah, so this is basically, in simple terms, is kind of a disaster. I would first, so the most crucial thing here, I'd say, before you do anything here, because it's not an emergency, is I would obviously get MRI and myelogram if that's possible. Yeah. I would also
she wasn't psychotic anymore, so
okay. I would also make sure this patient is optimized preoperatively. I'd make sure that if she has osteoporosis, it was treated. I'd want to get her on Forteo or some sort of bone building anabolic medication.
She's 32.
Oh, she's 32. Okay, I didn't see that.
32.
Okay. All right. So the goals of this surgery obviously are restoring her. So she's basically has PJF above at the top of this construct, which is severe kyphotic deformity. Above that, expandable titanium cage. and it looks like she's pitching forward over that. And it looks like maybe she's pulled out some of her screw. I mean, I can't really tell from this.
Actually, she is solidly fused here, and she's actually, it doesn't show up well here, but she has a solid bridge of bone anteriorly as well.
Gotcha.
So the issue wasn't that she fell over after the surgery. It's that this surgery didn't do anything. It didn't correct her deformity at all.
Gotcha. So I would try to, the goals of this would be obviously to remove some of the hardware. I'd want to get that expandable cage to be very, very difficult, but I try to go lateral on that. I get an approach surgeon. That'd probably be the easiest way of getting rid of that. Remove the posterior hardware, and I would just do an all posterior approach.
Well, you take the cage out laterally though?
Yeah.
Okay.
I mean, you could take it out posteriorly. I think it's just extremely difficult.
Yeah. Nader, what would you do?
Yeah, I mean, I agree. Thoracoabdominal approach to remove the cage. That's the first step, and then go from the back and you know, do a big, maybe a couple of like a 2-level VCR or something like that, and then put the cage back laterally. I don't know. This is a tough one.
Yeah. I won't lie, this was hard, but what we ended up doing is we ended up going completely from the back, and because she had posterior elements on the contralateral side from where he put the cage in, there was still virgin territory there, and so we exposed his costotransversectomy, and then did a contralateral costotransversectomy. So we basically completed a VCR, and then collapsed this cage and pounded it out from one side to the other, essentially. And then the cage was essentially encased in bone all around it. So it was actually very difficult to take out. And then just basically completed this 2-level VCR, and
Wow.
We ended up putting an XLIF cage in there. She healed that very well. So
This is, I mean, amazing that you were able to do that all posteriorly. Amazing. I mean,
yeah,
I thought like thoracoabdominal, remove that cage, and then go posteriorly, complete the VCR, and then put another cage. But wow, that's pretty amazing.
That was a tough decision to make, and we obviously told her that this may not work, that we may have to bail on this. So, but luckily we were basically able to pound it from one side to the other in order to get it out.
So you were able to engage the cage with the inserter and collapse it, and remove. Okay, so you knew what the cage was, and
yeah.
So that looks like yeah. Okay. Wow.
I think if we hadn't been able to collapse the cage, if we didn't know what it was, it would have been very difficult to take out, and I'm guessing we either would have had to take out another vertebral body because it was so encased in bone, or take a carbide burr and cut that cage in half, which doing that ventrally to the spinal cord is probably not recommended. So,
John, a lot of oh, I'm sorry, go ahead, Wendy.
What's that?
Razuli, can I ask a question? Since I missed it when I was called on before, I was listening. I apologize. I'm still working, so I had to take a page from a clinician. I did hear my name. But let me ask a question. So you asked what my approach would be. I can't say on that because I'm not a surgeon. But so Razuli said that he wanted an MRI and a myelogram and all this stuff. Did you have to get any of that for this nice result, the surgery that you did?
We definitely got a myelogram. Luckily, she was not stenotic. The MRI, and getting an MRI with that much hardware in was pretty worthless. So it was just.
That was going to be my question. I wondered if that would even be useful to you with all the hardware there. So.
No, definitely not.
Okay. John, it's a little bit past 7. Nothing but fantastic comments in the chat box, commenting on how great this correction looks. So,
Cool.
very happy about that. Are there any more cases, any quick cases, or should we
No,
just
that
wrap
was
it up?
it.
All right. So thank you very much. It was great having you. Do some awesome cases, and I hope that everybody here will join us next week. We have a very special session of Virtual Global Spine with Jennifer Strahl. She's going to be presenting several unique and interesting pediatric spine cases. So I'd like to see, or ideally like to see everybody there for the next session of Virtual Global Spine. John Caridi, thank you so much for being here with us. Some awesome cases, and I hope all of you have a very good night and a very good morning, and enjoy the rest of your week.
All right. Thanks a lot.
Take care.
Thank you, guys. Thanks, John.
All right. Thank you.